Hi, everyone. Welcome to session 4 of the Edward Kremers Seminar on the History of Pharmacy and Drugs. My name is Lucas Rickert. Just quickly, I'm an associate professor in the UW-Madison School of Pharmacy. I'm also the historical director of the American Institute of the History of Pharmacy. So I'm glad you can be here today. I'm looking forward to today's conversation. More generally, last year, the Edward Kremers Seminar, what we're lovingly calling our Kreminar, was launched to advance a few specific goals. So for those of you out there who are interested in pharmacy and pharmaceuticals or intoxicants and medicines, look, I thought it was important to sort of build some community for younger and more established scholars alike. I thought it was worthwhile getting us together to maybe share some insights that cut across periods and disciplines and subject matter. And hopefully we can advance some scholarship and generate some new ideas. That's precisely what we want to do. So if you like what you see today, by all means, spread the word around. Please remember too that all the talks from this year and last year's Kreminar and in all future Kreminars, they're available for viewing on the AIHP YouTube channel. Okay, so you can go back and watch these again if they totally blow your mind. So why Edward Kremers? Why are we calling it the Edward Kremers Seminar in the History of Pharmacy and Drugs? So he was the second dean of pharmacy here at UW. He was also a co-founder of the American Institute of the History of Pharmacy, and that was in 1941. He was extremely influential nationally in pushing humanistic approaches within health sciences and essentially building history, more particularly into public health and health sciences education here on the UW campus. And beyond that, he believed that we needed to be open-minded when developing interpretations and policies related to given substances and intoxicants in American society. And so he was a fitting person to name this seminar after. So before I go any further and introduce our speakers and everyone else involved, I'd like to acknowledge that I'm coming to you from traditional and ancestral Ho-Chunk land here in Madison. And it's important, I think, to recognize that. I'd like to thank my excellent colleagues in HSMT, that's the History of Science, Medicine, Technology, here on the UW-Madison campus, both in the Department of History, but also in the Department of Medical History and Bioethics. So that said, this year's seminar, our Kreminar, is a lot larger than last year. We have some excellent partners with the University of Kentucky's College of Arts and Sciences, as well as the Alcohol and Drugs History Society. So Dr. Claire Clark, who is an associate professor at Kentucky, is the co-organizer, and she's here. And hi, Claire. It's so brilliant to have you involved this year. It's awesome working with Claire. As well, Dr. Jonathan Jones, who's currently a postdoc at Penn State University and is moving seamlessly into an assistant professorship at VMI in the fall, is here doing a smashing job as a moderator for us. It's just like off the charts. So thank you. We're extremely lucky to have you here as well. So that brings us to the title of the session today, Unexpected Histories of Opioids and Overdose. And we are really lucky to have Dr. Nancy Campbell, the author of OD, Naloxone, and the Politics of Overdose, which was published by MIT Press in 2020, and Dr. David Herzberg, the author of White Market Drugs, Big Pharma and the Hidden History of Addiction in America, which came out with the University of Chicago Press, also in 2020. So together, we're looking forward to a fantastic conversation around a better understanding of prohibition markets in the United States. and how this helps us understand pharmaceutical markets. I think that they are putting forward some really provocative questions, very valuable questions for us to ruminate on. Why did certain pharmaceutical opioids and opioid antagonists come to matter the way they did? And when they did, particularly during social and political ferment of this sort of most recent opioid crisis. Another important question is, how does incorporating the story of pharmaceuticals change our understanding of the history of opioids, addiction, and overdose? These are really important questions that they're going to try and unpack for us, and they are in perfect positions to be doing this. Biographically, Professor Nancy Campbell is the department head in the Department of Science and Technology Studies at Rensselaer Polytechnic Institute. She is one of the pioneers and leaders in the field of STS and drug studies. She's written about policy and treatment, harm reduction, and gender and addiction. And I'm not going to go through the long list of publications that have been so influential. Professor Herzberg is based at the University of Buffalo, where he teaches history, but is also the coordinator of addiction studies, a newly emerging program at the University of Buffalo. He is a historian of drugs with a focus on the legal kind, addictive medicines. He's also got a long list of publications that I can't possibly introduce at this stage, other than Happy Pills in America, from Milltown to Prozac, which was published by the Johns Hopkins University Press. And I'm tired of introducing these excellent speakers because I want to hear them talk, and I'm sure you all do too. So you have the floor, and the microphones are yours. Thank you for being here.
So I'll just jump in here with a quick note about the format. Today we're lucky enough to have two authors with two wonderful books, and I have both of them here. They're a little blurry, but because we have two books today, we're going to mix things up a little bit. For the first 50 minutes or so, Nancy and David will be in conversation with one another. And what that will look like is that they will introduce each other's books, walk us through some of the key findings of each book, and then they'll interview each other. And I think that these are going to be really exciting interviews. Following that, I will jump back in, and the audience will jump back in for a Q&A period of about 30 minutes or so. So with that, I'll turn it over to you, Nancy, who's going to be discussing David's book.
Hello, everybody. So this book, White Market Drugs, Big Pharma and the Hidden History of Addiction in America, is an answer. It provides a kind of global answer to a question that I think is really the question that expresses so much of the work that we're doing to try to situate and understand current opioid crisis, which David refers to as the third crisis. And that is the question: how did it come about that the scientific heirs of the guardians of public health who set out in the early 20th century to prevent another heroin from ever entering the US market ended that century with a blockbuster opioid promoted as non-addictive that proved a ruthlessly efficient gateway to heroin, and now fentanyl, sending users of white market drugs to illicit markets in droves. So that long historical narrative comes down to a kind of really simple sentence. And I will be quoting from this book on a number of occasions in this kind of interesting conversation that David and I have been having on the margins of our conferences and for many, many years. So David recognizes that markets are always regulated, and that the question is really who regulates them and toward what end, for what purposes, and for whom. And so we learn, of course, again, that drug prohibition, right, like alcohol prohibition, targeted a certain type of person, urban, immigrant, and not just a psychoactive substance. But we also learn this really interesting thing about overdose that was very compelling to me as I was writing OD and thinking about it. Overdose deaths were 4 times higher from pharmaceutical sedatives alone than from all opioids in the 1950s, right? In that very first moment when we begin to recognize these as opioid overdose deaths in somewhat the way that we do today. This epic situation was concealed by the market system, which Charles or Ed Lindblom reminded us in a book of that name. Really works by mutual adjustment and at different scales, and not by any kind of centralized coordination. And indeed, the distractions of illicit drugs, the drugs I work on or have thought that I'm working on, as I began to realize that, yes, the collapse between the drugs medicine divide, that collapse is really what we are recording, documenting, and writing about. But it is the distractions of illicit drugs that were one of the reasons that the white market system, as David writes it, was so incredibly resilient over the post-war decades, despite the growing crisis. And so we all thought we were thinking about heroin. We all thought we were thinking with the illicit market, and yet what was happening, and it was always apparent to me within thinking about discovering addiction, because many of the scientists and researchers were cycling between pharmaceutical markets, pharmaceutical regulation, and the study of, quote, addiction, i.e. the illicit market. So this growing crisis, this epic growing crisis, gets covered over in some ways by the attention that is drawn by the distractions of the illicit market. And I am as subject to that, those distractions, as any historian ever was. So one of the things that was really interesting to me was we all have to make our own archives, and David assembled his and did a decade at least, right, of research that David has been talking about that. But he assembled a kind of treasure trove of letters. Although he's writing a lot about supply side policy and markets, he's also writing about consumers and users and patients and demanders, right? People who sought to maintain their access to these drugs. And so I wonder, David, if today you might start out by sharing some of that evidence and some of that, the treasure trove of letters with which you used to kind of turn received wisdom a bit on its head, because you're looking at the considerable impact of formal markets on white markets, pharmaceutical markets, on so-called prohibition markets. So would you be willing to share some of that trove with us today?
Yeah, I would. Thank you. And let me say before I've got just a few letters that I would put up on the screen. Let me say that one of the things that looking at what I call white markets, which are these pharmaceutical markets for the same products that we call drugs when they're sold on the street. One of the things that when you pay attention to them, you start to look at a different history of American drug policy. You know, America is famous for drug wars, right? Prohibition, stopping drug use. But these are markets in which the goal was to get psychoactive drugs to consumers in safely as possible and to get a lot of them. In fact, there's a large commercial infrastructure for doing this, and it's designed to get them to them safely. So it's a it's a system of distribution, circulation, purchase, and use that is premised on very different principles with very different goals. And yet, these are psychoactive drugs. There are people who sell them, and there are people who consume them. And so I wanted to remember that these people's stories should matter. We get, obviously, the illicit drug use has been spectacleized for more than a century, turned into this incredibly gripping spectacle and drama, and so that we can think that that's what drug use looks like. Those are what the experiences of drug use, the experience of drug dependence or chronic drug use looks like. And so these other ones need to be brought into that, in part because there's so many more of them. It seems important to explore their experiences, to have a fuller understanding of what it means to buy, sell, and use drugs. So let's see if I can share. There's just a few of these letters, and it's going to take me just a second to get to the right place on them. Are you seeing? Wait, hang on a minute. Okay, so are you seeing a PowerPoint? Yes, okay, good. Let me get to the right. So these, I wasn't looking for these letters. These are letters that I encountered in archives. I thought I was writing a pharmaceutical history similar to my first book, and I was looking for, if I could find corporate documents and regulatory documents. And then I found that consumers cropped up in all of these different places and in unexpected places. Here, this first letter you see here, which the highlighted portion says, "Please help me, I'm sick," and you can see from this paper enclosed that I'm entitled to have morphine. This was from a batch of letters quite early in America's prohibition regime, drug war, you might call it a little anachronistically, in which people who looked like the special kind of consumer that we call patients, that who have been given the sanction of the government and the medical system to use these drugs, that many of them had become dependent or addicted to opioids during this first kind of market free-for-all, before there was really much in the way of regulations making the sales of these drugs safer. And these folks often, not always, often were treated quite differently. They had different options available to them than so-called street users who were criminalized and were being arrested. These folks, in some cases, could work with a physician who knew them, particularly physicians who had been through the process of criminalization and their mindset had been formed before, opioid user equals junkie or what have you. And then, but there's a very precarious situation because technically it became illegal to provide opioids to someone who was addicted. And so this produced evidence, because sometimes a doctor who provided opioids to one of these people died or moved. And then this person was in a real bind. They had to ask a doctor to do something illegal. And this produced a batch of letters stretching from the early 1920s all the way through the late 1950s, so well into very serious prohibition times, that was asking the federal government to recognize their special situation. Look, I am one of these kinds of people who's supposed to be allowed to use these drugs, but I can't convince a doctor. Can you help me do it? And the kind of the belief that they had a right to buy these products was so strong that the most common kind of letter wasn't even just, will you give me authorization? It was, will you subsidize it? Like, I know I can buy these, but I have to go to the doctor every time and then to the pharmacist. This is so expensive. Can you just give me permission to buy directly from the pharmacy? So there are a lot of these letters, and they show an awareness of what it takes to qualify as a patient. They talk about suffering. They talk about being hard workers who want to, if they're women, take care of their family. If they're men, they're working jobs. And they often, in a lot of ways, allude to respectability, which includes those things, but also has strong racial implications. There are very few people of color who are writing these letters with the assumption that federal drug authorities are going to give them permission to use opioids. So this is one of them, and this is another letter here, which is from one of the authorities tasked with evaluating these pleas for opioids, and they're struggling with the language. But now I think we use the terms dependent versus addicted. This language was not present at the time. You can see here he's saying, well, he will be a better citizen as a legitimate addict, like a legitimate addict is someone who, you know, should be allowed to purchase opioids. So this kind of stuff runs through for a while, although it starts to peter out as this generation of, as the large bulge of people who can portray themselves as patients who were addicted to opioids by their contact with the medical system, by that, as that begins to dwindle as a proportion of opioid users. And then the second batch of letters I'll go through more quickly. It came from a different set of drugs, which I skipped over this, which came to replace opioids and cocaine in medical practice for these kind of consumers who were used to getting relief for what someone referred to, I thought really quite aptly, as the pains of existence. You know, opioids and cocaine, okay, well, those are too dangerous. Now we'll shift over to barbiturates, which is a kind of sedative, and their successor drugs, the minor tranquilizers, the benzodiazepines and such, and a different kind of stimulant, the amphetamine and amphetamine-like drugs. And you can see an advertisement here for one of these early barbiturates, and you can see the kind of person that they have in mind as a patient, a respectable or affluent white woman. So eventually, after there's this crisis that Nancy's talking about, made these drugs too start to seem like, well, we need to do something about oversale of these. They're really producing all kinds of public health harms. They were not entirely withdrawn from white markets, but their sales were curtailed very sharply, leaving once again a bunch of people, some of whom may have been taking, let's say, amphetamine pills every day for 25 years. And then in 1977, suddenly the state says it's illegal to prescribe for that person's condition anymore. What do they do in that moment? Well, there's another case where these kinds of conflicts produce evidence. They write letters to their senators, to their representatives, to their physicians, to the state medical board. And it's this one. They write things like, you know, the wife must have these to live a decent life. You've taken away her medicine. What are we going to do about this? And so at these moments, you see these consumers who are the kind of drug consumers who they rarely appear in drug history. And when they appear in pharmaceutical histories, they often appear as kind of as ciphers, as people who are outwitted by big pharma, or were just kind of like ignorantly searching for easy answers to life's problems. And these reveal them, as full human beings who are, among the strategies they're using to live are these pills or these morphine in the earlier action. And it helps us understand them as actors in this story, not as people who were hoodwinked by more powerful forces, but who were trying to make decisions the best they could within circumstances that weren't always of their choosing. And I will stop there. And Nancy, I hope that was what you were hoping for.
That is indeed what I was hoping for. So one of the interesting questions that I think throughout the book grows a sense of this emerging gray market that begins to emerge to serve, to some extent, the needs of some of these kinds of consumers. But it seems like your overall story in the book, right, is the story that white markets get smaller and safer. What happens to these kinds of patients, these kinds of citizens, right, who have legitimate claims? What happens as that kind of market shift occurs? I think we've often told the story, at least in my head. It was just as you stated it. It was, barbiturates in, opioids out, as if these masses of consumers simply did what they were told and moved between drugs that seemed to be safer, and each generation of psychoactives was advanced, of course, is non-addictive, is safer in a number of ways. And so what do we know from your book about what I call the dynamics of market shift, right? How do these people move? What moves them? They're obviously not necessarily completely in tune with the whole regulatory state and the regulatory systems. how does that process happen? That's a social change process, right? Can you talk a little bit about that?
Yeah, it's a really interesting question. And I'll say that I don't think individual people often made this shift. This is, as you referred to there, a generational shift. And one of the ways to think about this is that white markets are social institutions in which a lot of legitimate social resources were invested. And that meant that they just had a lot more resilience and give, not to mention just massive size. So let's take a situation where you start to have authorities cutting back on sedatives and stimulants. Well, we know from tragic and angering experience in the 21st century that one thing that can happen is when you just willy-nilly cut back on white market sales of an addictive drug, that means turning away people who have become addicted to that drug or dependent on that drug and saying, well, you can't buy quality controlled, FDA approved substance anymore. And we know that people are very motivated to continue to buy drugs in that circumstance. So they are forced to shift to more dangerous markets with calamitous consequences. That didn't mostly happen in the late 1960s, 1970s, as authorities started to scale back sales of these white market sedatives and stimulants. And one reason is because white markets are huge and they have a lot of powerful players involved in them and a lot of social protections, so that even when they shrank in a different way. So one thing that you pointed out there, one of these pressure valves, so to speak, were what we now call things like pill mills or script mills. I call them in the book gray markets, where these kinds of drugs would continue to be, even as medical standards change, and it was no longer acceptable to just prescribe amphetamines for everything or prescribe Quaalude for everything, that certain physicians, through a kind of an iterative process in dynamic relationship with their patient base, came to specialize in prescribing and selling these particular drugs with a careful eye to maintaining all the appearances of a medical relationship. So those consumers would still appear to be patients and the people selling the drugs would still appear to be doctors. And this made it more complicated to use drug laws to shut them down. There was a lot of protection there. And what this meant is that there was essentially a period of time in which you didn't just wake up one morning and the drug you'd been using for 20 years was just completely unavailable. You might have to do some more activity to find someone who could prescribe it, but there was time. And time turns out to be precious, because when is it that you're likely to experience a drug-related harm is in that moment of transition or shift when you're moving from the familiar to the unfamiliar. Now, eventually these kinds of script mills or gray market outlets would eventually succumb to medical authorities because they weren't really practicing medicine as defined at that time. But they're this example of this unexpected and imperfect ways that drug consumers and drug providers have adapted to, on the one hand, the real risks and harms that can come from mass production and sale of drugs, like that when profit determines how drugs are sold, that can produce a lot of risk for consumers. And then on the other hand, these kind of clumsy sledgehammer tools that we use for drug policy of like, they're good or they're bad, and if they're bad, you just end them. And as they navigated between these, it produces these unexpected outcroppings of certain kinds of behaviors, like this hidden archipelago of morphine maintenance in the early 20th century, when if you had a friendly doctor, you could manage that situation, to pill mills and script mills in the 1970s.
So you also talk about, and I'd be interested to hear a kind of consolidated version of your story about methadone and methadone maintenance as a radical innovation that challenges the basic architecture of white markets. You actually say that, and I think that's a really interesting way to kind of think about methadone and about the expansion of a system that is really different from anything else that we've seen, and that is specifically aimed at addiction treatment. So I think methadone is a pretty interesting example really for both of us. And it's one of the things that illustrates the need for historians, for us to really think about these sorts of gray markets, because of course it was diversion of methadone and methadone overdose that so fueled a lot of the regulatory climate around methadone, and brought in, of course, the DEA and the kind of, it really pointed out a lot of the kind of regulatory contradictions. So could you talk a little bit about what sense you made of methadone, why you call it a radical innovation in markets?
So markets are just a word to describe how drugs circulate in a capitalist context, like how they're bought and sold. And up until methadone maintenance, the premise of the way markets were organized in the United States was this divide between white markets, where these legal pharmaceuticals were sold to people who qualified as patients, and people with addiction were explicitly defined as no longer the type of patient that could purchase in white markets. Interestingly, those were only people with addiction to opioids. It was certainly frowned upon, but it wasn't illegal to give someone, Valium for many years every day. But so they were excluded from those markets, and instead people who were excluded purchased. People who were excluded are just like people who were included. Lots of people use drugs to handle life in various ways, to pursue pleasure, to relieve suffering, and so they too purchased drugs, but in what in the book I call informal markets. And since then I came up with a much better term of prohibition markets, which I regret not being able to go in and change in the book. But these are markets that had regulations, but those regulations were not designed for consumer safety. They were designed with different purposes in mind, many different purposes, from policing and surveilling racialized populations that were understood by white authorities to be a problem and a threat, to trying to minimize or even prohibit the use of certain drugs. And that gave these markets certain characteristic shape and structure that we were just talking before the event, that Eric Schneider described so well in SMAC. So methadone maintenance was an expansion of white markets to populations that had traditionally been excluded from them. It was saying people with addiction, particularly poor, urban, racialized people, now could buy a quality-controlled, FDA-approved opioid that was designed to make their lives better in the way that medicines supposedly are. And so this was a deep crack in that architecture, and you can sort of see the radicalness of it in how incredibly careful, to the point of almost incorporating methadone into the police or carceral system they were in handling it. Those weren't just the standard commercial controls over opioids. These were the kind of controls imposed over methadone sales to people with addiction were vastly more intense and more surveillance, more policing, more consequences than any. I can't think of medical treatments that are similar in that way, but it's still, despite all that, it was still remarkable.
Yeah, and it is a very interesting. You have, in the 1970s, like at the same time that this sort of methadone maintenance system is scaling up, and you have in that same era, you have bowls of Quaaludes sitting on the end of bars, and you have a kind of pill culture, consumption culture, right, that again is taking place at such a distance in so many ways from that other group of consumers who were formerly excluded, right? So there are lots of kind of niches and ways in which these markets open up to new kinds of behavior. A lot of your history suggests that market reform is important for a safer drug supply, for a number of social goods, not simply kind of commercial goods. You make some suggestions towards the end of the book about market reforms, and I'm wondering which of those you would say, I think that, this sort of idea of taking profit out of these kind of markets, it's a pretty interesting idea. I'm wondering which of those you might say, and we talked a little bit about the Quaalude situation in our preparation for this, because I had seen it as somewhat of a success story, right? I had read that as all right, so we don't have that particular form of danger to confront when we go into a bar anymore. But you have a different reading of that. And you also have a t-shirt that I think you want to show us as we transition to the other book that we're talking about today.
Yes, let's see. Oh, okay. So these are little ephemera about Quaalude, and referring to that pill culture you were talking about. There's the Captain Quaalude t-shirt, which found its way to a hearing in the House of Representatives. Whoever designed that t-shirt must have been proud. And then this is a kind of a scare magazine from a Sunday newspaper supplement about this demonic child offering Quaalude. So on the one hand, I think it's instructive to compare Quaalude and heroin. Both are drugs that were specifically criminalized. Quaalude by 1983 was made illegal. Like, it's no longer a medicine in the United States. But they're not the same story. And one reason is that Quaalude is one of a very big class of sedatives, just like heroin was. And just as in the heroin case, that the rest of the class of sedatives was not outlawed. They were, some of them were upscheduled, which meant they went into under the more tighter controls under the Controlled Substances Act. And what happened with Quaalude was more about trying to manage a mostly internal white market phenomenon to make white markets for sedatives safer rather than a true prohibition act. Because the reality is that while some people developed a particular liking for Quaalude, Quaalude is just a sedative like the others, with very similar effects and very similar risks. But a culture of use and a culture of sale had grown up around Quaalude that was producing problems, producing dead bodies of people who were using unsafely. And one of the possible strategies for addressing this was to encourage consumers to move from that part of the market, which was leading to deaths, to another part of the market where the drugs involved may be safer, might have less likelihood of leading to overdose, or just had different cultural patterns, like the social practices around the drug were less risky. And so by really putting the screws down on Quaalude slowly over time, it was added to one schedule in 1971, and then it was upscheduled in 1973, and then it wasn't outlawed until 1983. This gave a chance for people who were addicted, for example, to switch to some other sedative, which was still legal. You could still get from the doctor, you could still get continual supply from the doctor, or to change their drug using habits, either to stop it or find some other way. So in other words, once again, there was this give to the system, and you ended up with a market in which drugs were still available and yet safer. I'm not a drug absolutist. I don't think everybody has a right to be able to use to be able to have absolute freedom to get any drug they want at the moment they want it, just in the way that I don't think anybody, it seems like an impossibly libertarian ideal that everyone should be able to buy any consumer product they want whenever they want it at any time. I recognize there's going to be constraints that we make because we're part of a collective, we're part of a society. We have to have some constraints on these things. And this struck me as a constraint that was that the balance of cost and benefit was pretty good, given how difficult the situation is. And it wasn't like it was attendant to the social realities of drug use, in the sense that Quaalude itself is not that special a sedative. And as far as I'm able to tell, it really just isn't. It just happened to develop social practices that had become dangerous. And so it wasn't, it was really a strangely pragmatic and flexible form of supply side management that in the difficult and vexed history of drug policy does count as less bad, and which maybe might count as a success. Have I confused that issue enough, Nancy? Is that fair?
No, I mean, I think it's very, especially when we think about the collapse between illicit and licit, good and bad, good users and bad users, and the racialization thereof, less bad seems better. All right, so yeah, you want to make a transition?
Yes. I'm ready to make the transition, because one of the things that this one of the things that suggests, we were talking, my book is all about supply side and what kind of regulations like change the structures of markets and structures of drug availability. And Nancy's book is a brilliant exploration of the supply side. And one of the things that I kind of came to is, well, one of the goals of supply side is to make it as possible as possible to make it more possible for people on the demand side to make decisions to make good decisions, to make safer decisions, to make the kind of choices that are going to lead to drug use that helps instead of harms them. And so that the goal of supply side is to get out of the way in a good way, not in a libertarian, just every person for themselves, but in a way that allows the kinds of agency and decision making among people who are going to use drugs, which includes almost all of us. And this is what Nancy's book does so brilliantly. I'm going to give a summary just for people who haven't read the book, and then I have some questions for Nancy. This book operates on, I think, 3 different levels, distinct levels. On the one hand, it's a social movement history. It's a history of radical activists who changed large social practices despite wielding very little formal power. So it's a classic social movement history. It's also a history of science. It's about how certain things came to be objects of scientific knowledge and how unexpected different groups interacted in ways that you wouldn't be able to predict unequally, to produce both knowledge of certain types and to produce ignorance of other things that are kind of made invisible once you decide what things matter about what you're looking at. And then I think there's a third level in which I see it also as an argument that these two are actually the same thing, that social movement history and the history of science are not always the same thing, but really we should be careful in drawing distinctions between them too deeply because they share a lot of similar characteristics. So let me go through the plot, the narrative arc, so to speak, and some of the characters just to put a basis for the questions that I want to ask Nancy so she can get to the meat of it and not need to fill us in on those details. So the book recounts the origins and development of both harm reduction and naloxone, and how they came to be so intimately connected. How did harm reduction end up being so closely tied to naloxone? How did naloxone come so closely tied to harm reduction? And how did both come to be connected to this thing called opioid overdose, which I thought I understood much better before reading the book than after, because as Nancy points out, we actually know way less about it than we think we do. And it explores the unexpected consequence of the entwinement of these things. That harm reduction and naloxone coming together in this way produced a lot of things other than more naloxone and a lot of implications. And so the book explores those as well. It's divided into 3 parts, broadly speaking. Part 1 is, I think of it as kind of a prehistory of opioid antagonists like naloxone. These are substances that reverse the effects of opioids. And this prehistory is in the 1950s to the 1980s, when these opioid antagonists were discovered, but they were used for purposes not related to opioid overdoses. So they were not, those two didn't really overlap yet. So for example, in the 50s and 60s, one of the early antagonists was Naloxone, and these were used to test and to prove whether someone was truly an addict. Because if you gave an antagonist to someone who was addicted, it would precipitate withdrawal. And this led to building up an infrastructure of expertise around addiction based on like, aha, we have this, addiction is such a weird and woolly thing, so hard to tell is someone addicted, is someone not, but now we have something that proves it, and there's a whole infrastructure of expertise that gets built on that. And it's a specific type of expertise, Nancy points out. It was an expertise built with policing and social control in mind, and focused very much on pharmacology, things that could be, proved in a lab. And the assumption was it saw people who use drugs or people with addiction as defined by their pharmacology, and that's who they were. Who they were was the pharmacology of opioids. And so they weren't people who made decisions, they weren't thinking actors, and therefore there was a whole bunch of expertise built around the idea of controlling and policing this problem group. And that was the form of expertise that had been built up, she says, when naloxone was discovered. And as such, it was used primarily as a tool for studying the brain and maybe for making an abuse-proof opioid medicine so that these problematic people wouldn't be able to misuse our good medicines. It got a little bit, it started to get its toes wet in terms of being used as an overdose reversal, a tiny little bit in a Haight-Ashbury Free Clinic, but more so it was introduced in a very limited way among like emergency medical teams who would sometimes use it. But strangely, she points out, even though here was this thing that could save somebody's life, you have this counterexample of CPR. Everyone and their brother learns how to do CPR. Naloxone, not that. It remains this very narrow precinct of these medical experts. And that's in part because of the forms of expertise that had grown up around addiction and opioid antagonists. Overdose wasn't a social crisis. It was just this pharmacological thing that happened to people who use opioids. It was just a natural fact. So that's part one, this prehistory. Thus, the drugs come into being. Nobody is really thinking this will be our key tool for responding to overdose. And part two tells how that story changed. And in order to tell how that story changed, she changes who the story is about. Instead of the medical experts and expertise who built up focusing on pharmacology, focusing on social control and policing, these are the harm reduction activists who are busy cutting their teeth, trying to save lives in the HIV/AIDS epidemic in the 1980s and 1990s. And they did something that just how radical it was, like takes a while to unfold, which was needle exchange. And this at first, it seems like a very, in some ways, a simple intervention. Well, HIV/AIDS is spread by people sharing needles, so why don't we give clean needles? But what this does is it says people who are using drugs are not these inhumans who are defined by their pharmacology. They're actually people who are deserving of life, health, and dignity, even if they're going to continue to do the most stigmatized activity around, which is injecting drugs. And the success of this act and of this way of thinking about people who use drugs just reverberates through the rest of the book. And it opens up a way to think about using naloxone differently. A different kind of expertise comes out of these interactions with drug users, and out of that expertise comes the idea of using naloxone to reverse opioids. And it begins, some needle exchange programs began to also have naloxone and offer opioid reversal. And naloxone becomes a tool in a form of insurgent public health that's not built by those medical authorities from part one, but that is built despite them by people who use drugs, by people who used to use drugs, and by people who care about and care for those people who use drugs. Now, one of the most interesting, I think, parts of the book, intellectually speaking, is the movement from kind of insurgent discovery of this use of naloxone to trying to essentially scale up naloxone, scale up this public health practice from an insurgent thing to an institutional thing that can reach the number of people that it needs to reach. In order to do that, you need real social investment. Like, think about those white markets, all that money, those social resources to build that infrastructure. That's what if you really want to scale it up and make it available, that's the kind of stuff you need. How do you get that? Well, you get that by turning it into real public health. You need to, you need to provide proof that what you're doing is a public health activity that works to, to save lives. And so they become lay epidemiologists or evidence-based activists. The kind of terms Nancy uses are brilliant. They're lovely. And they're trying, on the one hand, they're just still doing what they've been doing, saving lives in their communities, but they're also trying to collect data and use this data to say, you should be giving money to us to do this because it's working. And that produces, all kinds of conflicts. This pursuit of legitimacy could lead to different decisions than the social movement aspect of this, the radical insurgent aspect. Is it more important to save a life, or is it more important to produce evidence that can lead to lots of money that might lead to more lives being saved in the future? Well, that's a mode of thinking. Are we going to start to see like a state and think about population health and this and that instead of this person who's right in front of us? So really fascinating exploration of those kind of dilemmas in these groups. And then part 3, and I'm going to skim over part 3. I'm sorry, Nancy, you can say more about it in the Q&A. Part 3 looks at attempts to institutionalize some of these harm reduction practices and where they were most fully realized, which is in Britain. And they weren't fully realized. There's all kinds of conflicts and compromises that come from this difficult task of kind of institutionalizing an insurgency and to try to retain grassroots-based anti-authority expertise, even as you start to capitalize that E and become official experts. And so she explores some of those systems. And then she closes the book with a look at the present, addressing what I think of 2 major and really urgent questions. Number one is, why isn't there more naloxone? Now that the evidence that it works is out there, why are there still so many overdoses when overdose can be seemingly stopped by this cheap and safe drug? And then the second one is a little more unsettling, is more naloxone actually enough? What if naloxone is kind of ripped out of this social movement with all its social and political goals and just adopted as a kind of a technocratic pharmacological intervention? Will that actually address the crisis? So Nancy, that's my brief summary of the book, and I would move into asking you some questions, but I forgot when I was doing this, as when we switched, because Nancy's naloxone shirt apparently isn't Zoom friendly. And so I was going to change, in honor of her book, change to this shirt from my local harm reduction agency to kind of emphasize this shift in thinking expertise around people who use drugs. So with that, Nancy, let me ask you the first question. In the book, you describe the group of activists and advocates who changed the meanings of naloxone in so many ways, not as actors or subjects. You describe them as protagonists. And this is a really interesting and important word choice. And I wonder if you could tell us why you made that choice and what lessons you want all of us who think about drugs and people who use drugs to learn from that choice.
Sure, it's a really good place to actually start to think about the book. I was interested in, and I, from the beginning, called them protagonists. As I began to interview people, as I began to try to understand what had happened to harm reduction with the advent, in a sense, of naloxone as that kind of tool. So the protagonists of this book participate in harm reduction social movements, which take different shape in different places all over the world. And I bring you this screen of a harm reduction photographer, Nigel Brunsden, whose photograph of Dan Bigg appears in the book, but who I encourage you to go to his website and to take a look at the iconography, the kind of visual iconography of harm reduction that he is producing. And that is partly because one of the problems of starting off a book like this, starting the research on this book, was that people who are drawn to harm reduction are not drawn to it by any unified theory or identity. They come to it from really quite a number of different kinds of experiences. Some of them are drug users from, who are seeking human rights. Others are professionals. Others are drawn to it out of social movement commitments that were other than harm reduction oriented. But they're very creative adapters of a technology like naloxone. But for them, I think we really have to think of harm reduction as a way of life, as a mode of living. And what I got onto after writing a book, not a book, an article, a simple article that turned out to be an amazing introduction to this with Ann Lovell on buprenorphine, which often appears as buprenorphine plus naloxone. And I knew a fair amount about the development of buprenorphine because I sort of regard myself as NIDA's historian, even though they don't regard me as such, telling the story of how buprenorphine and the sort of pharmacological dreams out of which it comes was what I was doing. And at the end of that article, one of these protagonists, Maya Jo Simpkins, who participated in the Boston response to overdoses on Boston Commons, called me up and said, you should write about naloxone. That's the next molecule, essentially, that you should follow. And as I began to realize, as I began to interview these kind of naloxone access advocates for what I really did think was going to be a very short article, I began to realize that there's this whole undone science of overdose, and this whole group of people who are interested in mapping the scope and extent of overdose in the 1990s, long before there's really any kind of public acknowledgement that overdoses, opioid overdoses, are gathering force and increasing. And so I amplified what I heard of the protagonists about the ways in which they came together. They often came together to assemble kits, and they often did a kind of these sort of exercises in group solidarity, often at needle exchanges. They traveled together. They took a kind of communal pleasure in their interactions with one another. And of course, part of that was sometimes at times mediated by drug use. But for the most part, this was a growing nascent kind of political and social movement. They traveled together to hearings at the CDC and the FDA. They convinced state medical boards to start allowing standing orders, to start, in a sense, legalizing naloxone, because naloxone, as David mentioned, it grew out of this older narcotic antagonist, nalorphine, and also called Merck's name for it was Naline. And so naloxone was essentially kind of illegal in a lot of places. And so these protagonists had to get together and figure out how to make it legal in all 50 states, in several different countries, and what legalized access to naloxone, would really look like. And so I wanted to show you just a few quick slides about nalorphine, because as David mentioned, part one of the book is really about that. And it's partly because I think that the experience with that first narcotic antagonist really conditioned or shaped the sort of notion that these antagonists were largely to be regarded as technologies of suspicion, that they were used in carceral settings and in punitive ways. Even if somebody came into the A&E or the emergency room, nalorphine was sometimes deployed in this kind of way, as is naloxone, and naloxone has been used in this way as well. Nalorphine, to just kind of recap a little tiny bit of the story of the book, was something that was clinically understood to reverse opioid overdose at the narcotic farm. These are photographs from the first US clinical trial, large clinical trial of methadone at the narcotic farm. In my life, everything always goes back to the narcotic farm. But Naline was widely advertised in the medical press in the 50s for including heroin overdose, right? It's mentioned in actually published medical ads, right, that there are such things as heroin overdoses, and this is how you can reverse them. But the main way in which that molecule was used was, I hope you can see the top of this because I can't, but it's very much about the war on drugs. It's about, it was conscripted by law enforcement as a weapon in the war on drugs, which, as we know as historians, began much before the Nixonian war on drugs. And so this kind of use by law enforcement and this kind of punitive use, you know, where you essentially inject someone, where the police, right, are injecting people who are suspected opioid addicts with nalorphine in their basements of police precincts, and checking what happens to their pupil size, is a really important prehistory, because it would help us understand why it takes naloxone so long to begin to creep into this more harm reduction, more social movement oriented context. Lawrence Robinson was enrolled in a Nalline program. The Nalline programs throughout California in particular were really thought to be deterrent, to deter heroin use for the most part. And they are also offered as one of the reasons that drug users turn to amphetamines in Southern California, because amphetamines and other white market drugs don't show up on the Nalline test. They don't, you know, we don't have any precipitated withdrawal, et cetera. And so that kind of was an important context for understanding what happens in the late 1960s and why this drug nalorphine, which does reverse opioid overdose, but which is much more dysphoric than naloxone, is not displaced by naloxone until well into the 1970s. We don't see naloxone out there except in the context. So during this whole moment, you don't see any real attention to nalorphine or naloxone as a tool of opioid overdose reversals. And in fact, as late as 1972, one of the major books that introduces the illicit divide that David and I are both so interested in noticing the implosion of, the collapse of, this book says very clearly, if we just got more nalorphine out there, the death of anyone due to heroin overdose should be very rarely excusable, right? So this is after FDA approval of naloxone, a much cleaner, much less dysphoric narcotic antagonist, has already been extended, right? But naloxone naloxone was a researcher's chemical in the 60s. It fueled these sort of pharmacological dreams that pharmacologists had about treatment drugs, about ways in which you could use naloxone or a narcotic antagonist to make a safer analgesic. And as you know from Caroline Acker's work, as well as my own and actually many others, there was an attempt to find a safer analgesic and to develop one. And we are still enduring the hell that has developed as a result of that search. But that search did change in the 1960s to, could we find maybe an addiction treatment drug, right, that would work a little better? And could we use a narcotic antagonist, find a magical ratio that would mean that we no longer had to deal with this major side effect of analgesics that is addiction. So David, back to you.
Let's see, I'd actually like to check in with our moderator, because I actually have a lot more questions for Nancy, but I saw that chat comment saying that we're switching to Q&A. How much time do I have, Jonathan, so I can triage these questions?
Yeah, we have a few more minutes before we can open it up to the audience Q&A. So take your time, and then whenever you're ready, we can switch gears.
Okay. Well then, Nancy, I think something that would be unlikely to come up in the Q&A unless people have actually read the book. I'm going to skip to this question about junk food, if that's all right, because I think this is a magazine that's an important source in the book, and interested to hear you talk a little bit about this magazine and why it's important, what role it played in building overdose and naloxone as subjects of knowledge production, and also just talk a little bit about some of the challenges you faced in building your archive for this marginalized population that everybody's always talking about and studying, but they themselves might not leave records in their own voices.
Yeah, I so envied your trove of letters, and because it was so very difficult, of course, to find subjective experiences, accounts of overdose, either because it was so stigmatized, either because people died, or because, as we now know, of course, from the science of overdose, typically people may overdose 9 or 10 times before an overdose that actually kills them. But there was this one place where I was able to find quite a bit of what I would call the kind of early cultural production around subjective experiences of overdose. Overdose didn't used to be represented. It didn't used to be represented visually. Of course, there were literary constructions of it. But for the most part, now, today, of course, we have an explosion, regrettably, a proliferation of overdose film, of YouTube videos, of all kinds of production. But junk food, which is the zine, was the zine, where's my cursor, of the Santa Cruz Needle Exchange, was, and specifically the Book of Death, volumes 1 and 2, where I actually found some of these kinds of accounts. And these were protagonists, the people who were producing this zine, especially Heather Edney and Brooke Lober, who are still involved in the harm reduction scene in California. Heather at Homeless Healthcare LA, and Brooke at St. James Infirmary in San Francisco, had developed this this project. And of course, the post-punk aesthetic and the kind of the things that you could do with Xerox machines back in the day contributed to the ways in which this zine was able to kind of introduce naloxone, but also overdose. And it really was about overdose and the experience of overdose and the experience of witnessing of overdose in others. And so that sort of aesthetic that they developed really contrasts greatly to ours 20 years on, but it emphasized this expertise. We are the experts. We are the authorities, in much the kind of way that, David, you were alluding to earlier. They put forward this notion that they knew that they were producing knowledge of a phenomenon that was not well documented, that medicine had essentially tolerated without really exploring, that science, it was very difficult for the people who originally embarked upon the sciences of overdose to do so. They did not get funded, and they had to kind of fit that in. They knew what they were seeing. So they knew that there was a documented rise of overdose in particular areas. But this was the 90s. This is, before we begin to see this kind of showing up in any way. And that aesthetic really contrasted to this one. This aesthetic, these are subway signs from Thrive, New York City, the New York City Department of Public Health. It actually derives from a Scottish naloxone campaign, which I'm not going to show you, but what I want to do here is showcase the narratives and the centering of different experiences of overdose and different experiences of saving someone's life with naloxone that we see in this kind of much more finished, much more upmarket, kind of product. Contrast that, right, to these Santa Cruz Needle Exchange junk food type collage art. But I think that it's a very important narrative for seeing the ways in which these kinds of social changes follow along with the kinds of changes that are made in the regulatory sector, in the political kind of governance that we decide to devote towards dealing with our opioid problem.
Thank you. Jonathan, I mean, I have enough questions going forever, but let me ask you if you want to switch.
Sure. Yeah, absolutely. So I also have a million questions, and I'm sure that folks in the audience do as well. But I want to open up with sort of, I want to open up the Q&A by asking Nancy a sort of bigger picture kind of methodological question, because I'm so fascinated by some of these sort of cultural history sources, like the junk food magazine images that we were just viewing. And so my question, Nancy, is this. You write in the introduction to your book, you write about learning to think pharmacologically. And for some reason that stuck out with me when I was first introducing myself to your book, learning to think pharmacologically. And I think that I imagine that that's the kind of phrase that will stick with folks who are sort of early in their journey through drug history as a field, you know, younger scholars like myself and graduate students. It's just such a powerful phrase. So my question is this, it's a two-part question. The first part is, what do you mean by learning to think pharmacologically? Could you just sort of give us in a nutshell your meaning of that phrase? And the second question is a brief follow-up. Was it difficult for you to mesh sort of the science of opioids that you describe in your book really well with kind of the cultural and social history approach to drug history? Like, was putting those two things together difficult? And if so, what sort of difficulty did you have in bridging that gulf? I hope those questions are clear. That was sort of a long-winded,
very clear.
Question, but
Yeah, and wonderful, because it fits very much into a kind of journey I think that I have made in response in some ways to Howard Kushner's work on taking biology seriously and the need for historians, particularly in this kind of a field, historians of science and medicine, of these kinds of psychoactives, to take biology seriously. I have, although I am clearly a social and cultural historian and therefore a dreaded social constructionist as a science and technology studies scholar, I have never not taken these molecules seriously or taken the pharmacology of addiction or whatever we want to call that phenomenon seriously. These are things that I had to learn, and actually harm reductionists also have to think pharmacologically, particularly because they are seeking to educate others. And one of the early images that I had of naloxone from Maya Doe-Simpkins was a set of slides that she used to teach overdose prevention and education. And it sort of looks like little receptors sitting on golf tees, and then, you know, naloxone comes in and knocks that opioid off the golf tee. And so I have long followed molecules. It's been my, in discovering addiction, I had to learn a lot as fast as I could from the pharmacologists whom I was interviewing. And I somewhat collected, made a little bit of a little, yeah, we're always assembling our own archives of how they thought pharmacologically and how they explain these things to me as a layperson. So I think it's a really productive way for historians of science and medicine to work by following the scientific descriptions, because of course science is society, science is culture. That's how I was trained up anyway. And the idea that, but they don't necessarily think that science is a form of cultural production. In many ways, I mean, we're here at the behest of the AIHP. In many ways, pharmacy, right, is thinking pharmacologically and educating others as to how to do that. And so I think those tools are really important. A kind of science literacy is essential to our field. I could not have understood this story if I didn't have some basics about antagonism, the concept of antagonism, and the concept of receptors. And so I think those are really important. And thank you for that question.
Oh,
Go ahead, David.
I was going to just add to that it's interesting because there's different ways of thinking pharmacologically, and then you think pharmacologically as part of thinking socially, as you were just saying there at the end. But in the book, the experts who think pharmacologically are actually producing a lot of ignorance about everything except for pharmacologically. So it's really important that way that you use the term is I think distinctive and important.
So we have a follow-up question that's directed both to you, David, and to Nancy. And it's sort of one of these bigger picture questions. And the question comes from Joseph Spillane. So I'll read it to you, and I'd love to hear how this question meshes with the issue that we were just discussing a moment ago. So Joseph asks, speaking of taking things seriously, he'd be interested to get our speaker's take on what the conceptual and or practical barriers to taking users and consumers seriously. So how can we take drug users and consumers seriously as historians is basically the question. And do you have any advice to folks who are starting out on their own research projects, their own drug histories in this area? Myself included. So this is kind of a greedy question for me.
You first, Nancy, and then I'll.
Oh, see, I thought you should go first on that one, but I obviously deal with a marginalized and somewhat stigmatized and often racialized population, and the barriers to taking, I mean, even maybe some of you, as you saw the illustrations about knowledge and expertise coming from these harm reduction activists who did not package their prose in the platitudes of public health. I mean, they were very confrontational. They in many ways were difficult to take seriously, and so that and even today. The difficulty of, people didn't archive this kind of ephemera. It's difficult to find. It took me a long time actually to find folks who were producing this kind of work. Now I've begun to see much more of it because I think there's been a floor, especially on Instagram. Just check out Ward 5B and you'll see daily productions of things that I had so much difficulty finding. That seriousness of the nature of what it is that you produce, as an authoritative, legitimate knowledge claim, and the tensions between the scientists, physicians, and researchers and the activists these were really challenging. They were very they were very difficult to kind of ferret out. And David?
Yeah, I'd say I have a different issue with the challenge of taking consumers seriously, which is in pharmaceutical history. So in pharmaceutical studies more broadly, like there is an incredibly pervasive and incredibly insulting tendency to disparage people who use pills, everything from Prozac to not just opioids, but all these pills. And I was lucky enough to take part in a book edited by co-edited by Trish Travis, who's one of the great movers and shakers in our little subfield, and that called on us to think about the role that gender plays in this kind of disparagement of pill users who traditionally have been about 2 to 1. Women take the antidepressants, they take the tranquilizers, these pharmaceuticals of all kinds, higher than the like women use the medical system proportionally more, but they are prescribed these pills even more than that, right? So a woman going to see a doctor is more likely to leave with one of these pills than a man going to see a doctor. And there's this assumption, there's a ton of anti-pharma books that barely talk about consumers at all, except as kind of hoodwinked masses. But when they do talk about them, the language is actually, when you really focus on that, it's often quite quite terrible. It's about people who are mindless, people who are, or maybe even to blame, like that sure, big pharma is bad, but it's because we want easy solutions, as if wanting an easy solution is some weird thing that we don't, like everyone wants easy solutions, whether we get them is another question. So thinking about how to take these drug users seriously for a whole different set of social reasons can be challenging. And really the first step, I think, is just simply deciding that these are human beings who may not be wielding a lot of power in the situation, but they can't just be ciphers, that you have to understand them as people making decisions, and that these people can be used by drug marketers and big pharma for profit. They can also be used by anti-pharma activists as examples of, in my book, often like innocent, ignorant white women who need smarter men to protect them from big pharma. Like, it's very difficult to carve out a path of agency and dignity in this world, and I think that that you start just simply by wanting to know their stories and paying attention to their stories. And I'll stop there because I'm having an interruption. And I have to leave for a second.
So Nancy, I'd like to follow up with another question for you, and that is a question about methadone maintenance and naloxone. It's sort of a comparative question here. And so my question is, and David's book also touches on this too, but my question is, if you could sort of compare and contrast for the audience the lackluster introduction of methadone maintenance programs in the 70s, which have been sort of marginalized, versus the successful recent mainstreaming of naloxone over the last decade. Could you draw any sort of first parallels between these two mainstreaming movements and then differences after that?
Sure. Although I have to, there will never be enough naloxone. When we actually look at how much one would actually need to make a real dent in the overdose death rate, it's actually we're still considerably short on that. So the lackluster introduction of methadone had a lot to do with overdose, and had a lot to do with concerns about diversion, and it had a lot to do with disciplining of that by that regulatory system of what was, as David said, a radical innovation, and one that was met with a great deal of conflict by not only the white market regulators and the illicit market regulators, but also users themselves, the public health systems, and the construction of a standalone methadone maintenance system, right, that really, as Herman Joseph's dissertation makes very, very clear, was stigmatized and marginalized and racialized from the beginning, right? So I think that you've got naloxone was stigmatized and marginalized, but the racial politics of naloxone were really quite different in the 2000s, right? So, don't forget that my story about naloxone, there is a kind of endemic market-related, because as Eric Schneider, writes about in SMAC, because those heroin markets, urban heroin markets, were physically located in Black and Brown communities, the endemic overdose situation was racialized, whereas the epidemic overdose situation by the end of the 1990s and into the 2000s had been whitened in a way that was really quite different. So the racial politics matter, and the racial politics also matter, of course, for the introduction of buprenorphine, which doesn't come until 2003. free, and despite 30 years attempt to get at least one alternative to methadone on the market, one alternative addiction treatment drug out there in a very different way. So the racial politics matter in that answer. I don't know whether David heard the question.
I didn't, and let me just apologize. It was a good news thing. The vaccination card for my youngest son needed to be procured immediately, and so nothing terrible is going on. But what's the question?
So the question was about comparing and contrasting methadone maintenance and sort of how it was marginalized versus the mainstreaming of naloxone a few decades later. If there were, so the question was basically, could you point out similarities and differences between these two drugs and how they were introduced?
Well, I guess one thing, and I'm sorry if I'm repeating, but one obvious difference is that methadone is itself an opioid agonist, which means that it can produce addiction and related harms such as overdose, and that means, you know, inevitably, if you want from the supply side, that introduces certain things that don't have to be a factor supply side with naloxone, you know, that those incredibly stigmatized, incarceralized, and policed methadone markets are, you know, they're a problem in the way that they produce stigma and they reduce access, but they reflect a desire to address a real problem that we've seen since then, which is that you do have to pay attention to the characteristics of opioid agonists when you're setting up markets for them. I don't believe that that the sort of policing and control aimed at end consumers is the most effective way to do that. It seems like a really harmful and problematic way to do that. That really we have much, as Kathleen Friedel often makes the argument, that we have wonderful carrots as well as sticks. Like there's a big market for psychoactive drugs. That's a wonderful carrot to get people who sell them to act right. You know, you can get access to a great amount of profit if you act right. And so that's really where those pressures would appropriately belong, I think.
Yeah, and I think so these are two of the big takeaways from both books, right? Is that the pharmacology matters. The pharmacology of the substances that we're discussing is important and shouldn't be lost in the details, but also that the sort of racial and gender identity and context of substance users and in which, you know, substances are used affects the fate of these drugs, right? And so with that in mind, David, I have a real curiosity question for you, and it's about Quaaludes. so let's talk about Quaaludes for a moment. You give in your book this wonderful, really memorable story and really teachable story, I think, about this guy named Dr. C, who dispenses Quaaludes to like hordes and hordes of students at UW-Madison, right? And so that story is a really interesting window into gray markets. And how sometimes in the 20th century, folks pushed back against regulation of things like Quaaludes. So I wonder if you could tell us a little bit about what Dr. C's story was, and also how, like, what insights we can learn from the defense of Dr. C by UW-Madison students.
Dr. C, it's a really interesting story. In some ways, it's totally unique in that he was a prominent and very accomplished and successful African-American physician at this time who was associated with you know, some forms of civil rights activism. And so in that regard, you know, when you're studying the markets I'm looking at, you see a person of color in there and you look twice to think, you know, that's these were places that were not necessarily hospitable to producing opportunities across racial boundaries. But at the same time, maybe because of this reason in part, he became so incredibly notorious. I found out, as a matter of fact, before I actually saw the papers on his case, hundreds and hundreds and hundreds of pages, Greg Higbee, the former director of the AIHP, mentioned, oh, there was this notorious Quaalude script doctor in Madison. I wonder if you're going to encounter him. And so what happened, he's one of these guys who, he didn't set out to become a pill mill prescriber. He was someone who was a little bit of a counterculture guy. He was he was fiercely assertive in his professional rights and in his judgment as a physician. And he formed this kind of a bond with countercultural students at UW-Madison. And as authorities tried to clamp down on his prescribing of Quaaludes and a lot of other drugs too, and not always in safe ways, particularly as the older he got, his prescribing got less safe. He began to have more of the patients who went there because they knew he was an easy writer, and less of the patients who wanted a different kind of doctor, until he was essentially, as far as I can tell, running a script mill after a long and illustrious career with lots of positions of prestige. And he did so, and he was not, there was no sense in which he was doing this for money. He was he believed ideologically in what he was doing, that doctors shouldn't be police trying to determine whether their patients really are suffering what they claim they are, that they should just respond to it. So he's an interesting story, and he allows me to comment on something that David Courtwright said in the comments earlier, which is, like, on the one hand, he provided some of this escape valve thing I was talking about, that he enabled people to access purchase of drugs that they were going to probably use anyway, and he was selling brand names that were quality controlled. They knew what was in them. But at the same time, it's clear that people would go there, get their prescription, and then sell them at a markup to friends, or that he would, write prescriptions for drugs that shouldn't be used together. And so there aren't, it just highlights how there are not perfect solutions in this. These are, highly desirable, highly dangerous substances, and the best we're going to be able to do is going to be deeply problematic, and there are going to be people who pay those costs no matter what we do. And we have to, one of the things I had to do in writing this book is to retune my eyes from thinking like thinking the way an activist might, of trying to aim at what would be great, and really just look for what was better than terrible, right? So, okay.
Yeah, and I think this is another one of the big takeaways from both books, is that there are no perfect solutions for drug policy. Right? I mean, this is a vastly complicated issue. And I think it goes back to sort of something that Ian Smith put in the comments just a moment ago. In Scotland, despite the successes of the Scottish Naloxone program, today overdose deaths are increasing. And so it's hard to know sometimes. There are no one-size-fits-all solutions, right? And I think as much as we would like to see easy solutions, it's a complicated issue, right? And so that leaves us in kind of a frustrating spot as historians, I think, sometimes. Another frustrating spot, and I hate to say this because this is such a great conversation and we've had a lot of audience questions, is that we're starting to run up against the clock, and I want to respect everyone's time. So I think at this point, what I would like to do is, if anybody in the audience has questions that they wanted to ask Nancy and David that they didn't get to, please shoot those questions into the chat box, and I'd be happy to forward those if Nancy and David are open to it. And with that said, I'll pivot now to Lucas Rickert, who will close us off. And again, thank you both, Nancy and David. I loved the books. I have so much more to say, but we'll have to find time in the future for that.
I'll just echo what Jonathan has said. It's so wonderful to take part in this very vital, interesting conversation. And it is a crying shame that the clock has run out. This conversation has built wonderfully on some of our previous talks, and I just have to remind you that the conversation is going to continue next week. So next week we have James Bradford discussing poppy politics, drugs in Afghanistan, past and present, and the hosts for that will be Dr. Claire Clark, and also another guest, Dr. Horace Bartolo, who's a professor of political science at the University of Kentucky. So I'm looking forward greatly to carrying on this excellent conversation. And I have to thank everyone involved here, especially our speakers and Jonathan. Also, thanks to all of you out there for being a part of this dialogue. And so I'll see you in a week's time, hopefully, and take care.